Under the Sea, the podcast for the inquisitive diver.
Ladies and gentlemen, welcome to the Scuba Goat podcast, where we explore the fascinating world of scuba diving and ocean exploration. Today's guest is a highly accomplished physician and scientist who specialises in diving, hyperbaric medicine and anaesthesiology. With over 160 published papers and book chapters, he is a recognised authority in his field. A co-author of the 5th edition of Diving and Subaquatic Medicine and the Hyperbaric and Diving Medicine chapter for the last 3 editions of Harrison's Principles Internal Medicine, Professor Simon Mitchell was honoured with the Behnke Award by the Undersea and Hyperbaric Medicine Society for his significant contributions to the science of diving and hyperbaric medicine. Simon is a consultant anaesthetist at Auckland City Hospital and a professor in anesthesiology at the University of Auckland. He provides on-call cover for diving and hyperbaric emergencies at the Hyperbaric Unit in Auckland, and he has also assumed the role of Editor-in-Chief of the Diving and Hyperbaric Medicine Journal in 2019. Aside from his academic and professional achievements, Simon has an impressive diving career with over 6,000 dives spanning sport, scientific, commercial and military diving. Elected to the Fellowship of the Explorers Club of New York in 2006 and recipient of the Dan Rolex Diver of the Year in 2015, Simon's most recent expeditions were Truk in November 2019, the Perth Resurgence Cave in February 2020, and a New Zealand project to take arterial blood gas specimens from an elite freediver at 60 metres in February 21. With his vast experience and expertise in the field of diving and hyperbaric medicine, Professor Simon Mitchell is a truly fascinating guest, and I am delighted to welcome him onto the Scuba Goat podcast. Simon, good morning to you, sir. How are you doing?
Yeah, good morning, Matt. Yeah, nice to be here.
Let's just turn your volume down a little bit on your end. I think one of the very first things that we've got to kind of look at and chat about is you. So why don't you just let us know where you first started to dive? How did you get into donning a mask and fins and getting wet?
I was really lucky, Matt. I grew up in a little seaside suburb in Wellington called Seatoun. Wellington in New Zealand has got this amazing rocky coastline where diving can literally be a after work or after school activity. It was after school for me. I was only about 10 or 11 when I started diving, and of course it was snorkeling at first, and it was just what the kids did. We all just got in the water, and everything back then had this magical quality about it. You got in the water and you were just confronted with all these things that you'd never seen before. It was just fascinating. I totally fell in love with it. And of course, as a boy, I wanted to catch stuff. So it wasn't long after that I graduated to spearfishing as a sort of extension of what we were doing. But, right back in those days, it was like we couldn't afford wetsuits. We had to wear jerseys. We'd light a fire on the shore, get in the water, freeze, get out of the water, heat up around the fire, get back in. But it was a magical time, and I remember it very clearly.
Yeah. And at what point did you end up starting to train for the diving then?
Yeah, well, it's pretty much as soon as I could. I did an open water diver course. It wasn't PADI in those days. It was the old sort of CMAS system. And I think I was 14 when I got my what was called basic scuba, I think, back then. And then I became an instructor as quickly as you could. I think I was an instructor at the age of 19, and then it all just progressed from there. I mean, it's one of the amazing things about diving, Matt, and I'll make this point probably again, is that you can make a kind of a career, well, I mean a recreational career out of it, but reinvent yourself lots of different times. Like I say, snorkeling became spearfishing, became scuba diving, became instruction, and then combined it with my job. My first degree was in marine biology, and I was a science technician for our sort of equivalent organisation to the CSIRO in Australia, or NOAA in the US. So doing marine biology stuff with diving, a bit of photography crept in at that time. And then after that, I did medicine, went to the military, and was involved with the operational diving team there, did rebreather diving and surface supply diving. And when I left the military, it morphed into technical diving, and photography was back in the frame. So, I've had a lifetime of diving, but it's cycled through different activities.
Yeah, yeah. That's a hell of a lot to unpack there, mate.
Yeah, sorry. Well, we don't have to unpack all of it. No. But, yeah.
So, did you, when you that first step into being an instructor, was that in New Zealand or were you overseas?
Yeah, it was definitely when it was in New Zealand, and again, it was under the old system, the old CMAS system. So it was quite a process, like it. I mean, I don't think there's anything wrong with the way it's done these days, where you can progress to being an instructor relatively quickly. The safety record of the industry speaks for itself. But back then, it was perceived that, becoming an instructor was a long and arduous thing. And, it took a while. And then we crossed over into the PADI system later on, about 1985, I think it was. And, I instructed. Diving instruction was how I paid my way through medical school.
Okay.
So even then, it was, diving was an integral part of my life, even when I was very distracted with the rigorous process of doing a medical degree.
Yeah. So you did one degree in marine biology and then decided that animals weren't enough for you, need to progress onto humans.
Yeah, well, the truth is actually, and maybe I'm torpedoing my sort of reputation in medicine here, that is that when I left school, I just simply wasn't good enough to go to med school. And in fact, it was something I'd always dreamed about, but there was no way I could have done it on my school record. I was diving too much when I should have been studying. And so I was a very average student at school. We used to have this thing called school certificate back in the old days, which was the first public exam you sat. And I actually failed school certificate science. And yet here I am, professor of anesthesiology at the medical school. I probably shouldn't say that in public, but look, it was nothing to do with fundamental ability. It was all to do with being obsessed with diving and not studying like I should have at school. So it wasn't until I went and did other things like the marine biology that I started to become a good student and getting the sort of grades that would be necessary for getting into medical school.
So at that, did you have any kind of idea at that time in your life that the two should meet? With the medical training and the diving. Did you see that at an early stage?
Sort of, yeah. I mean, once I got into medical school, then it did crystallize in my head that when I left there, when I got through the course, I would like in some way to try to adapt my career to diving. And it was in those years that I first encountered this guy called Des Gorman, who actually is quite well known in medical circles here in New Zealand, and was in Australia too. He was a prominent diving physician at that time, head of the unit in Adelaide, the Hyperbaric Medicine unit, Royal Adelaide Hospital, had a massive reputation. And I got in touch with him, and he encouraged me to think about diving medicine as a career. And in fact, serendipitously, he moved from Australia to New Zealand, to the Royal New Zealand Navy, about the time I graduated from medical school. So it was a natural thing to go from med school to working with Des in the Royal New Zealand Navy. And that was a terrific time. I mean, it was the early 90s, and we had this exuberant diving population here in New Zealand who weren't particularly good at following the rules, and we had a large number of decompression sickness cases. So it was a fantastic time for getting true experience-based expertise in diving medicine. And so I worked in the Navy with Des for about 8 or 9 years.
Oh, great.
Which was a fantastic grounding in diving medicine. And it was later that I moved into anesthesiology after I left the Navy.
So you were actually enlisted, I assume commissioned, being a doctor?
Yes, I was. Yeah, I was a commissioned officer in the Royal New Zealand Navy, and look, that was a fabulous time of my life. I embraced the naval life. I had a lot of deployments overseas on ships. I had some wonderful experiences, and saw some things and did some things I never would have done if I wasn't in the Navy. There's no question about that. The problem with the New Zealand Navy and my ambitions is that the New Zealand Navy is just a bit small to train you in the specialist fields that you wanted to go into. Whereas in the United States, they will train, and the UK, even Australia, they'll train their doctors in specialties like anesthesia, surgery, everything pretty much. The New Zealand Navy doesn't do that, and in order to become an anaesthetist, I needed to leave the Navy, so that's what I ended up doing.
Yeah, it's a shame because obviously they lose a lot of people doing it that way, but
they do.
You've got to follow your goals ultimately.
Yeah. Well, that's one of the reasons the New Zealand Navy, I think, is kind of understaffed from a medical point of view, because it's difficult to have a medical career unless you want to do it in an area that's specifically aligned with Navy interests. And basically they would train you in general practice or occupational medicine, but unfortunately not the sort of sharp end specialty that I wanted to go into, anesthesia.
Yeah. I remember looking at the New Zealand military, probably late 90s, early 2000s, because I was in the UK military and I was considering jumping ship over to Australia, New Zealand. But even as I think you call them blackhander over here, whether they're the same down in New Zealand, propulsions engineer, it was never high on the list. It was always the GPs and the dentists that they wanted, though. So I was just in the wrong trade.
Yes. Well, yes. Well, look, I don't wish in any way, shape, or form to sound like I'm disparaging my time in the Navy. I'm not at all, and indeed, it was what got me started. And Des was a high-level academic who supervised my PhD. They actually allowed me the time to do a PhD while I was in the Navy, and that's what got me started my academic career, my research interest in diving medicine, and all that clinical experience with sick divers. In 1995, we treated 100 cases of decompression sickness, which is a lot. I remember pretty much living at the hyperbaric unit in January. We treated 30 of those cases in January that year. And, all the years around then, mid-90s, it was a bit like that, not quite 100, but up there. So as a young doctor trying to get genuine experience-based expertise, it was terrific. And it's hard now, like the numbers of decompression sickness cases have fallen off substantially, certainly the number that we treat. And now someone coming into the field like me would really struggle to find the experience they need to call themselves a genuine experienced diving physician.
Yeah, I can imagine. And just to put that into context there, I was talking to a good friend of mine who's based on Koh Tao in Thailand, and she is the manager of the hyperbaric chamber that they put in there recently. And that little island is one of the busiest locations on Earth for divers wanting to do recreational diving and get into it. And I think last month they only had 2 suspected cases where they put them in the pot just to make sure. So to hear, 30 cases in 1 month, you guys down there were really going for it.
We were, but it needs to be said that has changed, and it's not that way anymore. Like we would be lucky to treat 20 cases in a year.
Wow.
So it's really gone down, and there's all sorts of reasons for that, but which we can talk about later if you want. But there are still some places in Asia, in fact, where they are treating large numbers of cases, but not usually recreational divers. They're usually indigenous sea harvesters. There's a few spots in Asia and China where people who are doing, fishing at a sort of occupational level are getting sick quite often. So there are still some places in the world where they treat a lot of divers, but we're not one of them anymore.
Yeah. No, that's good to hear. Not too good, like you say, for people coming into the industry, but it's good to hear that people are being safe. I suppose over the years that you've been doing this, you've obviously seen a massive change in the understanding of the pressure on the body as divers. we do get many people listening to the show that are relatively new to diving. So would you mind just giving us a background or a quick overview of the basics of what decompression sickness, decompression illness is?
Sure. Well, decompression illness, and it's often not appreciated fully, is a collective term for two different disorders. One is decompression sickness, which creates some confusion because illness and sickness sound very similar. And the second problem that exists under that umbrella of decompression illness is what we call arterial gas embolism. And that's probably the quickest one to explain, so I'll deal with that first. So divers will all be familiar with the fact that they've been taught to breathe normally, never hold their breath. And that's because if you hold your breath and ascend, then expanding gas can damage the lungs and introduce bubbles into the bloodstream, the arterial blood, and that's what's called arterial gas embolism. And those bubbles can travel to all places in the body, but the place we worry the most about is the brain, because they can produce stroke-like symptoms, which can be serious or even fatal. So that's arterial gas embolism, and it's actually relatively rare. We talk about it a lot, particularly in diver training courses, to try and prevent it appropriately, but it's actually not very common. The second problem, decompression sickness, it's kind of completely different, even though it involves bubbles, just the same as arterial gas embolism. It's a very different mechanism. So that's the one where when we dive, we're breathing compressed gas for a period of time. We absorb some of the inert gas. So if it's an air dive, that's nitrogen. And then as we come back to the surface, decompress, that gas wants to come out of solution. And what we want it to do is diffuse from tissues into the blood and be carried back to the lungs and be breathed out. But what it can do is actually form bubbles, especially if we come up too quickly or don't do an appropriate amount of decompression. Although it must be said that most of us do actually form bubbles, even on dives where there's nothing gone wrong and where we don't get any symptoms. And those bubbles seem to be relatively harmless. But if there's enough of them, or if they're in the wrong place, then they can cause harm. So those little nitrogen bubbles, they can form in tissues. And classically, we talk about the bends because that's a manifestation of pain, bubbles forming in the pain-sensitive structures in our musculoskeletal system. But the bubbles can get into the blood, and that they can travel around the body and cause various symptoms. Of course, we worry the most about neurological problems like spinal cord involvement or the brain or the inner ear, which can produce quite dramatic and quite serious symptoms. But that is a very different problem to arterial gas embolism. Like that, lung damage and arterial gas embolism can occur in incredibly shallow water. Like you can do that in a swimming pool if you get it wrong. So even like a meter deep, whereas it's impossible to get decompression sickness in that setting. Whereas decompression sickness requires that you go deeper and longer, and the deeper and longer you go, the higher the risk, obviously. So yeah, that's a quick walk through decompression sickness and arterial gas embolism, collectively referred to as decompression illness. Is that what you were kind of getting at? Is that the sort of overview you wanted?
It's perfect. Yeah.
Okay.
Yeah, it is a very confusing subject for most people, especially, even for experienced divers. It's good to refresh on these matters.
Yeah.
So obviously, when we go diving, we've got the RSTC medical forms and asking about pre-existing medical conditions, etc., etc. Are there key elements that you've seen over the years that may amplify the chances of being affected by decompression sickness?
Well, there are some medical predispositions to that, but mostly those are not really things that you would typically pick up in a routine diving medical. So I speak specifically of a thing called patent foramen ovale, which is a little communication between the two upper chambers of the heart, which we all have when we're in our mother's wombs, because it allows blood to bypass the lungs, which you don't need when you're not born yet. But in some people, that persists after birth. In other words, it doesn't close like it's supposed to. And that allows blood from the veins that has quite a few nitrogen bubbles in it to get across into the arterial side. Normally those bubbles would be filtered by the lungs and removed, and they don't get onto the arterial side of our circulation. But if they can do that across a patent foramen ovale, then that is a predisposition to certain forms of decompression sickness, including the more serious forms. Now, we can't pick that up in a routine diving medical, and we usually only discover it after people do suffer those relevant forms of decompression sickness, and we do a test for it. But it's probably worth pointing out, since you've raised the issue of diving medicals and the RSTC form and the history we take there, that the most important element of that is not predispositions to decompression sickness, but more your general health. And it's blokes like you and me, actually, Matt, that it's targeted most at, because of all the diving fatalities, about a third of them are due to some kind of cardiac event as a predisposing injury, as it were. So in other words, someone has a heart attack in the water and ends up drowning. And so the diving medical is more focused on excluding those kind of problems than it is the underlying predispositions for decompression sickness. And actually, one of the weaknesses in our system, one of the big weaknesses, is that you and I can have a diving medical at the start of our career, or in fact, maybe not even have a medical. You fill out the RSTC form, it's a screening questionnaire, and there's nothing wrong with it. It works well, and I say that because I helped design it. And if there's no positive answers on the screening questionnaire, then you go into your diving course and you do your diving course. And from that point on, it's possible to have an entire diving career and never interface with the medical system again, unless you do another course or you're required to have a diving medical for some specific reason. But we're not very good at health surveillance. In other words, keeping an eye on our health over the years as we get older. I mean, I started diving when I was 14. I'm going to admit on air, but that's 50 years ago, right? So, I could have gone that entire time with no interface with the medical system. As it happens, I go to a GP regularly. I have checkups because I've seen too many friends get into trouble with cardiac issues over the years that are undetected. So those are the things that the diving medical tends to focus on, or the medical screening focuses on, rather than the trying to identify underlying causes of decompression sickness.
Yeah, which is why you've got that tick box for anyone over 45 that picks on me straight away.
Absolutely right. Anyone who's over 45 should actually, the form is quite sensible. Like, you should see a doctor, but if you walk into a doctor's surgery and can give a convincing history of superb functional capacity, like I'm Matt Waters, I run a marathon once a week. I don't get any chest pain, and like that would probably tell me that I don't need to do any more investigations on you. But if you're, overweight, unfit, have a family history of cardiac problems, and you're a smoker, then I would probably think very strongly about investigating you for cardiac issues further. So it's getting people at that risk age into the system so that they don't miss something that's important and could result in their death in a diving environment. Yeah.
Hey, one thing I'd like to pick up on, actually, you just mentioned they're smokers. I'm an ex-smoker, so I'm now Mr. Anti-Smoker and hate it. I can smell it 1,000 meters away. But is there a massive? Have you seen or got any kind of evidence of smoking being a major addition to issues when diving?
Yeah, look, the truth is, no, we don't have strong evidence that smoking is a risk factor for specifically for the things that I've been talking about.
Yeah.
However, there's a massive evidence that smoking is a risk factor for heart disease. And heart disease has been proven, hard evidence, this is not speculation, to be the disabling injury in 30% of diving fatalities. So right there, you've got a really good reason not to smoke if you're a diver.
Yeah.
However, it's also almost certainly true that smoking predisposes you to lung conditions that might make pulmonary barotrauma more likely, but we have no real proof of that.
I find it quite interesting because obviously being an ex-smoker, and I took that leap. I was a smoker for 35 years. And then when I gave up, I couldn't believe how much better my lifestyle got, and in particular in the water.
Oh, look, diving aside, in my role as a physician, I would say to anyone watching this that if you're a smoker, the single most important step you can ever take to improve your general state of health is to give up smoking.
Yeah.
And it will improve your financial situation. There's all sorts of benefits as well.
Yeah.
But, smoking, I mean, I would say, Matt, that in some point in the future, people will look back on the age of smoking and go, did they really do that? Like,
I know.
That's just crazy. But I think people will. I think that some point in the future, people will look back on that. Like we look back on how they used to send kids up chimneys to clean them out, or, and they'll go, no way, like puffing smoke into your lungs, you got to be joking.
Yeah.
Anyway, that rant over.
No, it's okay. I keep ranting at my son about it because he does like part-time cigarettes, but he's on vapes all the time, and it's in his mouth 24/7. It's ridiculous, and God knows what he's doing because there's no studies or no proof on what's going on with those things at the moment. But it's just all chemicals. It's just crazy.
Yeah, no, not a good thing.
I'll have my little rant on it as well. So Marcus, if you're listening, stop vaping. Oh, hey, one thing I wanted to ask or highlight as well is the advantages of being underwater for people that are disabled and special needs, because I've been doing a fair bit of helping out with Lindy Leggett from the Scuba Gym, and I think she's doing an absolutely outstanding job. But it led me to think, with this chat coming up with you, is about the larger roles of hyperbaric oxygen therapy. Can you talk about that at all, on how it's used outside of diving as well, and the benefits?
Yeah, of course I can. Look, first of all, let me just pick up on your comment about the special needs divers. That has been controversial over the years, but as a physician and the sort of one of the so-called gatekeepers in terms of fitness for diving, I think a certain amount of caution is necessary when you're selecting people to do those kind of programs. You just need to make sure they don't have any major problems that would be associated with increased risk underwater. But I am 100% supportive of those programs. They do a fantastic job for properly selected participants, and in fact, there's published evidence now, a number of publications in the journal that I'm editor of the psychological and physical benefits of participating in those kind of programs. So I'm very supportive of that. But jumping to hyperbaric oxygen. So as you've quite rightly pointed out, recompression and breathing 100% oxygen has been the gold standard therapy for treating decompression sickness for fairly obvious reasons. You compress bubbles and you get rid of nitrogen more quickly if you compress someone and breathe oxygen. And perhaps not so obvious mechanisms, but hyperbaric oxygen has some biochemical effects which are advantageous in treating bubble-induced injury. So, that's obvious to any diver. They know about that literally from day one, that decompression sickness or arterial gas embolism, you get recompressed. But hyperbaric oxygen, so the administration of oxygen under pressure, is also used, as you quite rightly point out, as a treatment in certain medical problems. And there are a relatively small number of those problems where the use of hyperbaric oxygen has been supported by good data. But the most prominent ones that we would use hyperbaric oxygen for, say in Australia or New Zealand, would be non-healing wounds, particularly in diabetics and particularly in the lower limbs. Radiation tissue injury. So it's not a well-known fact that when people have radiotherapy for cancer, they can develop tissue injury, which can last a very long time and indeed can get worse over time and produce quite disabling symptoms depending on where it is. And hyperbaric oxygen is pretty much the only thing that encourages that tissue to develop new blood vessels and heal. So just those two things alone are quite prominent indications for hyperbaric oxygen. There's about 10 or 12 others that are also on the list of things that we would consider established by sufficient data to justify the use. The biggest problem with it is that hyperbaric oxygen is relatively easy to administer. You don't actually have to be a doctor to do it, and it's been abused all over the world for the treatment of just about anything. And typically by people who will take money off you for putting you in a chamber and giving you what I would call false hope. Yeah. And it's a major problem in the field. And I have written with one or two of my colleagues, I've written extensively about this because it's a real blight on the field. And one of the problems with it that's sometimes not recognized is that all of my non-hyperbaric colleagues out there in the wider world look at that, so they'll see a list of 100 things that someone says they can treat in a hyperbaric chamber, and they just look at that and they go, that's just quackery, which it is, of course. But they form a judgment about the entire field based on seeing those kind of things. And so it drags the whole show down. So the patients that really would benefit from it, like the diabetic ulcers, the radiation tissue injury patients, don't get referred because the doctors looking after them think that the whole field is full of quacks and it's not something that they would subject their patients to. And that's tragic because it does work for certain things. But there's an awful lot of misinformation. And of course, the internet's the worst thing for that. Like you'll find no shortage of people who are trumpeting the benefits of hyperbaric oxygen for all sorts of things, typically things that have some kind of cognitive psychological overlay. Because you think about it, Matt, if you were to design the best placebo intervention in the world, it would be a hyperbaric chamber, right? You come there once a day, massive commitment and expectation. You're greeted by all these staff who are lovely to you, and you meet other people, which might not be the case for a lot of patients. They have these social interactions which might not be normal for them. They go into this chamber that is sort of quite adventurous, and it heats up on compression and it cools down during decompression, and they breathe oxygen in there, and this whole milieu of stimulation is a potent placebo if you're suffering from a problem that has any kind of cognitive overlay to it. So, it's no wonder that people who have, for example, chronic neurological disorders like chronic fatigue or multiple sclerosis that fluctuates a bit, or any number of things. It's no wonder that when they go into a hyperbaric chamber and have a course of treatment that they believe that it's actually helping them. And in fact, there's been multiple studies looking at this now in various indications like chronic brain injury from trauma, where the placebo, where they give they have two groups. They give one of them real hyperbaric oxygen and another a sham hyperbaric oxygen treatment. In other words, it's the same experience just without the hyperbaric oxygen, and both groups benefit. Both groups say they got better, but there's no difference between the groups. So anyway, that I don't want to go on about that for too long, but That is one of the problems in the field with hyperbaric oxygen, that it gets abused by people who take money off patients for a treatment with no real proof that it actually is beneficial.
So, I mean, this is the first I've heard of this. These are private companies that are linked into the medical care structure and get referred to. And does the Medicare or the government assist in funding this stuff, or is it completely on the backing of the patient to do it of their own accord?
Yeah, typically the latter. So in Australia, there are units, there are publicly funded units or units that can bill Medicare for certain indications, but they only will pay for the things that it actually does work for. So mostly it's patients paying for it themselves, which is another thing that really offends me. You're taking money off these people who can't afford it, for a treatment that doesn't work. I mean, for a physician, there's nothing worse, in my opinion. I just think that that's terrible.
Mate, I've literally just I've just punched into Google hyperbaric chamber, and the very first page that I've opened, its very first sentence is, "Our pressurized hyperbaric chamber is a non-medical wellness device."
Yeah, well, you'll probably find that advertisement is for what they call mild hyperbaric treatment, or a chamber that doesn't pressurize you to very high pressures, and you may even just breathe air in it, and they'll be touting it. Like it would be just the same as putting a plastic oxygen mask on sitting in the corner of your living room in terms of the oxygen dose, and yet they'll sell you that or put you in one of those and charge you money for it, claiming that it works for all sorts of medical problems, but it doesn't.
Yeah. I'm actually, I'm going to stop looking at that page.
Yeah, no, I would. Well, you might be signing up for it, of course.
Mate, I think you've just opened a big bag of worms that I'm not going to be able to get. That's
no. Well, look, I don't. I don't think we should spend too much time talking about hyperbaric treatment, but except to say that it is a thing and it works for certain diseases and diving illnesses. Decompression sickness and arterial gas embolism is two of them, and then there's a limited range of other things. But there's an awful lot of bollocks out there on the internet.
Yeah, I know. I've literally just seen it. Okay, let's move away from the bollocks and the quacks. Now, one thing I do remember from my years instructing all the time, when you talk about DCS, DCIs, the quantity of symptoms or the range of symptoms is just truly astounding. Can you narrow it down a little bit for, maybe people that might be quite nervous of, do I have the bends? Is there obvious symptoms that would stand out?
Yeah, no, that's an interesting question. It is difficult to narrow down because the truth is that decompression sickness, so we're talking about the consequences of bubbles forming from dissolved gas coming out of solution. It does have a very wide range of symptoms, and one of the problems is that those symptoms are what we would refer to as non-specific. In other words, they can be symptoms of lots of other things, which makes it very confusing to make a diagnosis. And one of the biggest challenges in diving medicine is getting a call from someone who's in a remote location. They might even be on a liveaboard dive boat where evacuating them would be a massive challenge and, of course, ruin the trip for everyone else on the boat, etc. And they've got these non-specific symptoms that are quite hard to sort out. Anyway, that wasn't really your question, but the point is that the symptoms are varied and they can be quite difficult to separate from other things. However, the most common symptoms are things like musculoskeletal pain, and I would say this, that pain can arise from a whole lot of things, but the pain of decompression sickness is quite distinctive. I've actually had musculoskeletal decompression sickness twice, and it's like this deep, boring ache that is a bit unlike, the pain you get when you strain a muscle or for a start, movement doesn't usually make it worse, and rubbing it doesn't make it better. And it's like you can't do anything about it. Both the times I've had it was in my upper arm, not so much my shoulder, but because people talk about pain in the joints. And I think this pain can kind of happen in lots of different places, but the most common places are upper arms, shoulders, hips, knees. So in association, probably with the pain-sensitive structures around those major joints. So pain. And then another common problem is a rash, which can take multiple forms. It can look like a sort of allergic rash, and then it can also present as a sort of a much more bruised looking appearance, quite a scary looking rash. We call that cutis marmorata, and it's fairly distinctive when you see it. So pain, a rash. Other common problems, those are the common mild symptoms, and then probably the most common serious symptom are weakness or numbness in the limbs, particularly the lower limbs, that would suggest that you've got spinal involvement.
Okay.
And that's probably the most feared symptom of decompression sickness that occurs moderately often. It's still, compared to the pain and rash symptoms, it's actually quite uncommon. And then you can get other symptoms like very significant dizziness, or what we call vertigo, or hearing loss after a dive. That's because the bubbles are involving the inner ear. And there's a whole variety of other things. I mean, I think walking right through all of the symptoms of decompression sickness, we could spend a lot of time doing that. And I'd endorse your point that it's a disease with a wide variety of symptoms, many of which can be caused by other problems. And I think the thing I would say to divers is, look, when you get symptoms after diving, then there's a good chance that they're diving related, right? Unless it's some kind of bizarre coincidence. So what I would, especially with the more serious symptoms, it's important that you don't rationalize and say, okay, I've got this symptom, but I'm going to try and attribute it to something else because I don't want the stigma or the blame for getting decompression sickness. And actually, that's a very good and important point to make, is that, when we got into diving, especially in the older days, there was this thing that if you get decompression sickness, then you must have done something wrong. And now we have a much more sophisticated understanding of that. It's not true. People, especially in the more advanced forms of diving, like technical diving, where they're doing decompressions, these decompressions are just sort of estimates of what puts your safety level at an acceptable level. They're not absolutes. They're not binary outcomes. So if you do your decompression, you definitely won't get sick, and if you don't do it, you definitely will. It's not like that. You can do everything right and still get symptoms, and you can do everything wrong and not get symptoms. So don't rationalize. Just if you've got symptoms, especially the more significant ones after diving, you should contact the diving emergency service, whatever it is in whatever country you're in, and talk to an expert. That's why those services are available 24 hours.
Yeah.
And divers have this tendency to do this, especially guys. They don't like to get that diagnosis, and so they get to the surface and they are really dizzy and vomiting, and they'll say, "Oh no, I'm seasick," and I'll go and lie down for a couple of hours, and when they finish lying down, then they find they can't move their legs. Also, these are the things that can catch people out.
Yeah. Quick break, mate. I need to pee.
Okay.
Oh, that's better. This is a morning recording. Last time I did a recording, it was with Pete Mesley, so it was beers and wine, and I think we were stopping every 20 minutes at that one. I have talking about that. Just picking up on what we were saying there. I've got a good buddy of mine, and I won't name him, but he's a dive professional. And years ago, we were diving together, and we come back up to the surface, and just a standard recreational, no decompression. And is this common? Do you get this as well? And his skin, you could literally feel it like like the popping, wrapping, bubble wrap. I'm like, dude, that's really not right. You need to get that checked out. And on return to his home country, he brought it up with his doctor, who then sent him on to a research team, and he ended up doing, I think, 2, 3, 4 dives or something like that in a controlled environment with them to find out why he was getting, I think it was a subcutaneous hematoma, if that's right, yeah. But there was no result. They couldn't understand why he was getting this, and they checked him for PFO and all that kind of stuff. And he's an absolutely fantastic diver, perfect trim, perfect profile, everything. And he's just, I think it's fair to say that he's a bit of a freak of nature. There's just been no understanding of why it occurs with him, but it's literally every dive he does.
That's really interesting. He may actually have contacted me, I think, to ask about that. I have had a couple of people raise those kind of things with me. I mean, if you're asking me why, I mean, given that he's been extensively investigated and no issues found, I may be in no better position than, well, I certainly am not in a better position than the people who've investigated him to speculate on that. But subcutaneous emphysema, particularly if you find it up around the base of the neck, in that skin and in this sort of area, or up in the neck itself, that can indicate that you've got some kind of leakage of gas out of the lungs that's getting into the sort of central chest area and migrating up into the tissues around here. And in fact, that's really the only circumstance under which I've ever felt what like the bubble wrap, and it's vanishingly rare. I mean, you almost never see it. But why you would get that? I mean, where was the skin where you could feel it? Which
on his forearm?
On his forearm. Oh, yeah, well, that's very unusual. I mean, certainly what I was just discussing wouldn't cause that. So that suggests that he's getting bubble formation in his skin. And I mean, that's a very unusual presentation, and probably is explained in some way by some kind of strange circulatory problem that, like he's loading gas during the dive and then getting vasoconstriction, which stops the gas washing out of the tissues, which could conceivably form gas, under the skin so that you could feel it. But I've never seen that. I have heard of it, but I've never seen it in a very long diving medicine career. I've never actually seen that. I've certainly felt bubbles under the skin around the base of the neck from pulmonary barotrauma, but I've never seen that.
So on the back end of what you've just said there, and with your superior experience and knowledge in this, I'm going to confirm that I can still call him a freak of nature.
Yes, I think that's fair. Yep, that's definitely fair.
Okay, so moving on a little bit, and you mentioned age earlier on, arterial gas. How is that? Are the symptoms significantly different, and what are the kind of long-term consequences
of arterial gas embolism? Look, it's in many respects a bit like a stroke. So, the bubbles will go into the cerebral circulation, so the brain, and they block, if they're big enough, they'll block blood vessels, which produces things like you see in a stroke. So it can produce unconsciousness, it can produce a hemiplegia, so a paralysis down one side of the body, either upper limb, lower limb, or both. It can produce visual changes or loss of vision, speech difficulties, thinking difficulties, anything that can happen in a stroke. Now, the thing that separates arterial gas embolism from a typical stroke is that a stroke is caused by a clot or something solid. And unless you get that clot removed pretty quickly, you will likely end up with some kind of permanent effect from your stroke. Bubbles are a little bit different in that they actually can redistribute and not block the blood vessel. However, if they're big enough and they block it for long enough, just like a stroke, you can get permanent paralysis, hemiplegias, you can get permanent visual loss, permanent cognitive function changes, permanent speech changes. But the spectrum of long-term effects goes right through to complete recovery. And indeed, it's not that uncommon for a diver to come to the surface the classic situation is a rapid ascent where people forget to breathe normally or hold their breath. They go rapidly unconscious, wake up and they're confused, and then everything goes away. And that certainly happens. So full recovery spontaneously without any treatment is certainly possible. But at the other end of the spectrum, permanent disability or even death is certainly possible as well. So it's a very variable thing, and that probably depends very much on the size of the bubbles, the gas load that gets introduced into the circulation.
And presumably, when we're looking at a dive profile, if the diver is working excessively, then that must increase the chances of getting symptoms of either.
Well, working
DCI, DCS.
Yes, that's so. Decompression sickness, where you absorb nitrogen and then it comes out of solution as you come back to the surface. There's a whole bunch of things about a dive profile that we look at in trying to make a judgment about how likely decompression sickness is after the dive. Now, sometimes it's obvious that we're dealing with decompression sickness, but then other times when the symptoms are more subtle or non-specific, like I said before, can be caused by other things. Sometimes we then focus a lot on the dive profile and what happened on the dive in assessing the risk, so that it gives us a mental picture or a yardstick against which to judge the risk of the dive. So things like the profile itself is obviously critically important. So the deeper, the longer, if you come up too quickly or you miss decompression stops, then obviously those are all factors that point us towards a higher risk. But then you just mentioned, working. If you work hard, you think about a typical dive, right? You work hard, or at least you're working when you're swimming around the bottom, but during the ascent, particularly on a decompression dive, where you're just kind of hanging out in the water, you're not working. And when you're working on the bottom, you've got lots of circulation because your heart's pumping more, the blood's flowing more, so you take up gas more quickly. But when you're resting on the decompression, that's the kind of the opposite. So your heart's not pumping as much, your blood's not circulating as fast, and so washing that gas that you've absorbed out of the tissues is actually a slower process. So that asymmetry in working between the bottom phase of the dive and the surfacing phase is a risk factor. And another classic example of that is temperature, right? So think about a typical dive. You jump in the water, you're warm at the start of the dive, you're swimming around, you're warm. That's when you're absorbing the gas down at the bottom. But then during the decompression, when you're not moving so much and it's, time's dragging on, that's when you get cold. And when you get cold, you get blood vessel constriction. That's exactly how your body defends against heat loss. So you get all this peripheral vasoconstriction, so that your circulation through your tissues during the decompression isn't as good. Again, a proven risk factor for decompression sickness. And let me say that, this is not just theory. The risk associated with increased work at depth and getting cold during decompression is well proven by hard data. And then there's a few other things that people talk about, like, being dehydrated and being fatter, with a higher percentage of body fat, and a few other things where the data are less convincing. But, certainly it's one of the things we look at, Matt, is, when someone contacts us, we are very interested in the diving they've done and the profile that they used and the circumstances of the dive. Was it warm? Was it cold? Was there hard work? Was there not? All those things are things we factor into assessing the risk of the dive.
Yeah. It's one hell of a rabbit hole to go down, isn't it?
Oh, it is. It is. And it brings me right back to some of the comments I made earlier about experience-based expertise. It's really challenging for a practitioner who hasn't isn't a diver themselves, perhaps, and hasn't dealt with a lot of divers and hasn't seen enough cases to develop that pattern recognition that we rely on quite a lot in medicine, it's very challenging for them to confront a diver on the phone and well, confront's the wrong word, but like speak to a diver on the phone and assess all these things that I'm talking about and wrap it all up into a final decision about what to do with that person on the end of the phone. It's very challenging.
I suppose one of the difficulties, like you mentioned earlier on as well, is especially with men, will be that bruised ego and just washing over. If you're trying to get it from a conversation on the phone, you're not getting that visual indicators of a bit of bullshit going on to try and.
Oh no, for sure. And I'm always a little bit wary about what I hear on the phone. So, any experienced diving physician will tell you that they'll have seen lots of cases where what you get told on the phone and what you see when the diver ends up with you are two very different things. And often they're a lot worse than what they implied they were on the phone. So the phone conversations, if I get any sense that I'm dealing with something that could be serious, I'll usually opt for a relatively conservative stance and evacuate the diver. Now there are exceptions. We certainly don't evacuate everyone we have a conversation with, and indeed that's one of the reasons we're treating less cases these days, because we recognize we've defined we've made a definition of mild decompression sickness, and we have an international consensus that says if the diver really does only have very mild symptoms, then it's okay to manage them without evacuating them and recompressing them. That, of course, doesn't mean I wouldn't recompress someone like that. If they were here in Auckland, of course I would. But if they're on Bikini Atoll and it's going to take a $200,000 slightly hazardous evacuation to evacuate someone who's got a bit of mild elbow pain and nothing else, then I would probably manage that person at Bikini Atoll rather than try and evacuate them. So these days we do make judgments on this. But getting back to my point, if I was nervous about what the person was telling me and I got any hint that they might be obfuscating more serious symptoms, I usually opt for an evacuation.
Yeah. Well, speaking about the evacuation, once you've decided that you're going to evacuate someone and use the pot, as it were, how do you go through the process of determining the appropriate treatment plan for that patient?
Do you mean in terms of the evacuation or what we do with them when they get to the hyperbaric chamber?
Yeah, when you get back to putting them inside.
Well, look, the truth of it is it's a fairly generic process. We have one. There's several options for the recompression profile, but there's one very generic option called the US Navy Table 6, which is a 4.75 hour recompression that involves compressing them to 2.8 atmospheres or 18 meters of seawater equivalent for 3 20-minute oxygen breathing periods, and then decompressing over 30 minutes to 9 meters seawater equivalent or 1.9 atmospheres. And there's a couple of 1 hour periods of oxygen breathing there, separated by an air break, and then a final decompression to surface pressure. Now, that can be modified a little bit. You can extend the period of time you spend at both of those pressures. But look, if all you ever did, no matter who you are, anywhere in the world, treating decompression sickness or arterial gas embolism, if all you ever did was the US Navy Table 6, then you couldn't really be criticized for that, because there's no real evidence that anything else is any better. But some places, and we've indulged in this kind of thing over the years, we sometimes recompress to a slightly deeper depth. If we get someone very early with very serious symptoms, we'll sometimes do that. Sometimes use different gases, especially when you go beyond 2.8 atmospheres or 18 meters of seawater equivalent in a chamber. Can't use 100% oxygen anymore because it becomes too toxic. So you have to breathe something else, and we'd rather they didn't breathe air. So often we'll use heliox mixtures for those kind of recompressions. But that's getting quite heroic, and there's no real evidence that it's any better than just doing that standard US Navy Table 6, maybe making it a little bit longer if they've got very serious symptoms. So there's not a lot of variability in that. That's the truth of it. It's, it's not the most complicated intervention in medicine, one would have to say.
Fair one. Well, is there any cases that stand out to mind that you can discuss that have maybe piqued your interest or challenges?
Well, the interesting cases are the ones that are, like somewhat paradoxically, in terms of outcome for the diver, the most interesting cases are the sickest ones, because they're challenging and they're interesting. I hasten to add that one would prefer they didn't happen to the diver, but when they do, those are the ones that are interesting. And one of the fascinating things about diving in the last sort of 20 years, we've had this, advent of technical diving, and because these divers are doing deep dives, and I'm obviously one of them, right? So in no way, shape, or form is this any sort of criticism. I do it, but so I might as well use the term we do these deep dives that require decompression, often quite substantial amounts of decompression, and of course that introduces the potential for things to go wrong and failure to complete the decompression. So you get people coming up too quickly from dives where they were supposed to do a whole lot of decompression, and what that creates is people who are very sick. So they get what we might call fulminant decompression sickness, and so they, in medical terms, are shocked, hypotensive. Their blood pressure's low. They have all sorts of biochemical and hematological derangements. They might be paralyzed in all four limbs, and just very unstable, intensive care type patients. And I was involved in a case. Well, I've had a number of these over the years. Thankfully, they're not very common. But I do remember one in Sydney, a technical diver who, a good friend who came up rapidly from a 110-meter dive because of a fault with a rebreather, and he was incredibly sick. The sickest diver I've ever treated who actually made a full recovery. And I can talk about it because we actually published it as a case report in Diving and Hyperbaric Medicine journal because it was so interesting. He was so sick. And yet he actually made a full recovery, young, fit guy, and had a few things line up for him. He got treated very quickly, diving off Sydney, and when the accident unfolded, the rescue helicopter was actually in the air doing a retrieval exercise. And so when the guys put the phone down from ringing the ambulance service, they could actually see the helicopter flying towards them, like literally 30 seconds later. So that was a very lucky break in that case. And it turned out that at Prince of Wales Hospital, they were also running a intensive care in the hyperbaric chamber exercise. So when he arrived, like all these stars, other than the accident happening itself, obviously, which we would prefer didn't occur, all these stars aligned in his treatment, and he had a terrific outcome. But he was very sick.
Are you allowed to name the guy, or is he stayed?
Oh, I won't name him, but I can provide you a website address where you can actually look up the paper that describes the whole case. You can download it for free.
Brilliant.
So I'll provide that to you, and if your readers want to read about that case, they can.
Yeah, I'll stick that in the show notes for sure. Okay, so you're kind of bridging the gap between professional divers, recreational divers, sports divers, military divers, and the medicine world. In your opinion, are we doing everything that's possible to promote safe diving practices, or do you think there's more that we could do?
It's a difficult question, but you probably can never do enough. And I do think that the industry is reasonably good at self-reflection and making appropriate recommendations where we see problems. Now, implementing those recommendations and getting compliance with them is another challenge. But I do think that I think we're pretty good at that. I mean, we've already seen one example in this podcast. So I talked before about how a cardiac event is the disabling injury in 30% of diving fatalities, and the industry's response to that is to ensure that the screening questionnaire identifies those people who are at high risk of that and ensures that they have a medical evaluation before they go diving. Entirely appropriate. That's a good example of it. I mean, I've just come back from Rebreather Forum 4 in Malta, where we had 3 days of presentations, and then at the end I actually chaired the consensus session where we pulled important points out of the various presentations that had been made, and a lot of those were safety points, and crafted them into a series of consensus statements, which are effectively recommendations for industry and divers. And an example of that is a very strong advocacy for the use of pre-jump checklists before rebreather divers jump in the water. I mean, like if you look through at the causes of rebreather deaths, probably more than half of them have occurred because the diver jumped into the water with their oxygen cylinder turned off, or their rebreather turned off, or their diluent cylinder turned off, or their dry suit not connected to its inflator. Just those 4 or 5 things, if everybody had checked those, check and response with someone else just before they jumped in the water, it takes about 45 seconds, then we probably would have had half the deaths we've had, because those things are incredibly common. So, we recognize that, and the industry has strongly advocated the use of pre-jump checklists, very simple killer item pre-jump checklists. And there's another example of, self-correction by a diving group. I mean, Rebreather Forum 4 was a collection of divers as much as anything else, but it has self-recognized that these are issues and has advocated for an intervention, that use of checklists, that will help prevent those things. So, I think that we aren't bad at advocating for doing the right thing. Getting divers to do the right thing is another story, of course, and I have no magic wand to wave in that regard, Matt. I would say this, though, that where we want divers coming through to exhibit good practices, I can't overstate the importance of people like us, you and me, and senior divers, so people that others modify their behavior on, setting a good example. And I can tell you, I will not go onto a dive boat with my rebreather and not use a checklist before I get in the water. But I do not want people seeing me do that. And, well, for a start, I value my own safety, so I don't want to make any of those mistakes. But, I just will not do that, because it's critically important. If other people who are, influenceable can watch me, then I want to model good behavior, and I do not want to set a bad example. And that's critically important in our industry. Instructors have to do the right thing. Yeah.
And it's not even under the teaching umbrella either. It's if you are an example of professionalism within our industry, as a dive professional, you should be very vocal and very clear about doing your pre-jump checks, whether that's on a rebreather or just on a single tank recreationally.
Yeah, well, you're right. That's right. So a buddy check, and that gets omitted a lot. In fact, you almost never see it done. And I disagree with that too. I think that we should be doing those checks. I cannot put my hand up and say that every time I've jumped in the water for a simple open circuit scuba dive, I always do a buddy check. And I should. You're quite right. And, taking my own previous comments on board, the reason I focused on rebreather divers in the way that I did is that we have hard evidence that those things are critically important in causation of rebreather fatalities. There's no question about that. Slightly less of a well-proven thing for the efficacy of doing buddy checks. Having said that, there is no doubt that they will enhance safety, and they should be done. I actually think we could do a better job at designing them. Like begin with, review, and friend. I mean, like an organisation like Paddy, with all its resource, couldn't they come up with a better mnemonic than that? I mean, we used to say botulism with runs and flatulence, I think, and we had a whole bunch of, we tried to make it a bit more interesting and spicy, but surely they could do a better job. But you know what I mean. I think that those checks are important, and we should be doing them in all forms of diving. You're absolutely right.
Yeah. I like. I mean, obviously, you're going to be an advocate of him as well, but the way Gareth Locke is just kind of opening up that kind of protection of embarrassment that people seem to feel about doing checks, and just being honest and open and getting shit done with checklists and pre-jump, and honesty after a dive site with review and feedback, etc. I think the more that develops within our industry, then the safety factor's surely going to go up through the roof, in my opinion.
Yeah, I think that there's good evidence from other industries, and aviation is a classic example, and medicine, my field, is another classic example where the use of checklists, for example, is a proven strategy for reducing mortality and complications in the operating room. Now, Gareth, yeah, absolutely right. He is probably the most identifiable advocate for bringing the broader field of human factors into diving, and that's not just checklists. Of course, checklist is an important part of it, but any strategy that will reduce the chances of errors or omissions or violations where people make conscious choices to do bad things is obviously welcome. And his advocacy for talking about accidents and being open and honest about them, so a just culture where people don't get judged when they do this, that's all really important stuff. And I totally agree. Gareth does a great job of that. He was at Rebreather Forum 4 and spoke about his passion for that over there as well.
Yeah, I did see quite a few of his posts. It looks like he sat in on literally every presentation that was going on.
Oh yeah, he did. Well, no, it was a single stream meeting, so you could, but he didn't. Yeah. I didn't see him duck out of any of them. He's pretty passionate about it.
Oh hell yeah, that's good. Okay, let me just flick through a couple of these questions we've got here. Oh, I'll tell you what I didn't mention, or what I'd like to touch on briefly. When we first started to chat, I touched base with you because I'd had a laryngospasm at 24 meters, and it was not long after I'd seen Stephen Fordyce's presentation at Oztech. Now, well, you can explain what a laryngospasm is better than me, surely. But if you were to, listeners, if you were to look it up on Google and just check out the videos, you'll see it's a pretty horrific thing to go through, let alone be doing it underwater. Are these pretty damn rare, or is it kind of struck out to me that, for two people to be voicing them, whether they're more common than what I thought?
Yeah, no, good question. So just to be clear for those listening, laryngospasm is when, let's step back and say the larynx is what a lot of people commonly refer to as the voice box. So it's this organ that sits at the top of the airway, the trachea that goes down to the lungs, and it has multiple functions. It has the epiglottis, which flops down when you swallow and stops any food getting down into the airway, which you don't want. And it also contains the vocal cords, which can tighten or loosen and come together or move apart in order to make the various sounds that we make when we're speaking. So it's actually a vital organ and, very important to our, quality of life and our ability to communicate, etc. Now, one of the things that can occur with the larynx and the vocal cords is that if the larynx gets what you might call a fright, or it gets stimulated in a noxious way, the vocal cords can snap together, and that will block the airway, and that's what we call laryngospasm. And interestingly, when you get laryngospasm, the bit of the breathing cycle, so breathing cycle is inspiration and expiration, the bit of the breathing cycle that gets impaired is inspiration. Expiration actually works because you're kind of forcing gas out through the cords from the chest, whereas inspiration that pushes the cords apart, the vocal cords apart, whereas inspiration sucks them together when you're trying to draw gas in. So it's inspiration that's worse, and we get this thing called stridor, which is when during inspiration you get this sort of, either you can't inspire at all, or if you can, if the vocal cords are sort of very close together, you get this kind of high-pitched noise, which, I mean, if it happens to you and you're awake, it's terrifying, because you feel like you're being strangled or asphyxiated, which is effectively what you are being. You are being asphyxiated. It's just you hope that it's going to break before you become hypoxic and unconscious. Now, you're right. So there's been several episodes of this occurring underwater. And to answer your original question, I think it's very rare. I'm a diving physician, well connected in the diving medicine community and the diving community, and I've only heard of a few episodes that I think are genuine laryngospasm underwater. Why can it happen? I think one possibility is that if you get water into your airway and you get water landing on the vocal cords, or you're unlucky enough to have a bit of snot or something land directly on the vocal cords during breathing, that could precipitate laryngospasm. The interesting thing about the case you mentioned, Stephen Fordyce's case, is that almost certainly happened because of negative pressure inside his airway induced by wearing a rebreather on his side, a side mount rebreather, and going steep vertical head down to get through a passage in a cave, so that the counter lung of the rebreather was up way higher than his airway. So there might, I don't know, but maybe 50, 60, 70 centimeters of difference in water depth. So the counter lung's up here and the airway's down here. And that means, because the two are connected to each other, that means that the pressure in the airway was the same as the pressure up here, higher, because this is shallower. So the pressure in the airway is lower because because the counter lung's shallower. And that means that there's this negative pressure inside the airway, which during an inspiration might be enough to suck the vocal cords together, and then they'll go into spasm. And that's what it sounds like happened in Stephen's amazing scary video. And he was really lucky. It broke, as it usually will, but it'd be terrifying while you're in that state of being almost unable to inhale. You can exhale, but not inhale. So you breathe out, and then you can't actually breathe in again. So, there have been several cases, and I think, there's two broad classes of cause. One is some kind of irritation of the vocal cords or the larynx, like water or snot or something else, or regurgitated stomach contents, something like that. And the other potential cause, is hydrostatic imbalance, where you get this counter lung being at a very different, shallower depth to your airway, and on a say a side mount rebreather, which can possibly do it as well. But fascinating. Yeah, really interesting. I'm really hoping Stephen will write that case up, and we can publish it properly in a diving medicine journal.
Yeah, for sure. I know we'll probably talk more about it. He was actually the first person that I touched base with when it occurred, because when I heard his presentation at Oztech, I'd already had a laryngospasm, but it was on the surface. It was just in between dives. I'd drunk some water, and as you say, I assume it was water that touched the vocal cords and caused. And I assume underwater it was water that got on the vocal cords as well. But seeing his video and his presentation, I'm like, holy shit, that's what it is, because I never really paid any attention to it.
Never figured out what it was.
Yeah. I didn't bother looking into it. But it was for me, it was the knock-on effect that comes from it as well, having that experience underwater. It was the first time, and I won't lie, I was shitting Tiffany Cufflinks. It was the closest and the most understanding that I've had of panicked divers. Just having that mental idea that I need to go, and I'm at 24 meters, and then the professional side of me saying, no, don't be stupid, you've got to stay here and sit this out. And it only lasts about 30 seconds, but yeah, the knock-on effect was I think probably 15 or 20 dives before I could actually comfortably be in the water again and not be thinking, shit, it's going to happen again.
Oh no, it would be terrifying, no question about it.
Hyperbaric medicine, what do you think the future is for it? I mean, you've obviously seen its growth over many, many years now. Where are we going?
Well, I think the key there is to properly research the various things that it might be useful for. As I alluded to earlier, there are a couple of indications where there's pretty good data from studies that show that it works. So, I mentioned diabetic foot ulcers and I mentioned radiation tissue injury, but I think the key to wider acceptance for further indications, in other words, diseases you can treat, is proper research. Not this, we think it might work for this and we'll just do it and charge people money. You need to do proper trials. So the future is identifying things where it makes biological sense, where maybe there's been a few cases that seem to have responded well to it. So, okay, let's do a proper trial. Let's prove this and therefore gain wider acceptance amongst, the medical community that this is a legitimate indication. That's the future. Now, whether we get there or not, because we haven't done a terrific job of that so far. I mean, follow the money. That's the problem. People just want to make money. So they're looking for things that they can charge money for and that they can treat now. And there doesn't seem to be any shortage of people prepared to pay money for treatment for things where it hasn't got adequate proof. But the future, if I could wave a magic wand, the future would be proper trials in a relatively limited number of conditions where it might work, and establish those things as either established indications or not. Good evidence or not. That's what we need. The situation we have right now. I mean, getting back to the point I made before, if every diabetic foot ulcer and every radiation tissue injury in Auckland that actually could benefit from hyperbaric oxygen got referred, it would keep 2 or 3 hyperbaric units busy full-time, 24/7. You don't need anything else, actually. The problem is those patients aren't getting referred. And the reason they're not getting referred is all this bollocks activity by people who drag the reputation of the field down. And so the physicians looking after these patients think, oh no, I'm not going to refer them for that because it's, here's this advertisement for treating everything under the sun with hyperbaric oxygen. It must be bollocks. That's the point. If we stuck to an evidence-based, ethical practice, then we would get all the referrals you could possibly need to make your hyperbaric unit successful. But unfortunately, we're in this kind of vicious circle where there's too much unestablished practice out there, and that creates a poor reputation for the field.
Yeah, it's unfortunate. How about we bring it up the other way? What's been some of the most rewarding aspects of the work that you've done over your years?
Well, in terms of diving, in recent years I've become, I've been a technical diver. Well, recent years, the last since I left the Navy 30 years ago, I've been involved in technical diving, and since 1998 or 99, I've been a rebreather diver. And I've had the most amazing experiences as a diver. I could there's too many to kind of articulate, but I would say that probably the single most rewarding thing for me in diving was way back in 2002, when Trevor Jackson and I dived the wreck that was thought to be Australian hospital ship Centaur off Brisbane. It was 180 meters. No one had ever dived it, and at the time, actually, it was the deepest shipwreck dive that had ever been done. And we dived it because we'd obtained some video from when that ship had been discovered 10 years earlier that we thought made it look possible that it actually wasn't the right wreck. And yet this was gazetted on the government website as on charts as the Centaur. There was a church on the nearest point of land. There were trips out there for families to throw wreaths over the side on that site, and here we were thinking maybe it's not even the right ship. So we dived it and indeed found that it wasn't the right ship, which created quite a lot of controversy at the time. 60 Minutes made a program about our dive where they essentially shamed the government for accepting the report from 10 years earlier. That was done with an ROV. So someone put an ROV down, got some sort of vague, it's a shipwreck. They claimed it was the Centaur, and no one really questioned that. And yet, 10 years later, we dived it. It's not the right wreck. And it was a bit unsatisfying because, we disenfranchised all these people who thought they knew where their loved ones were. But the good thing that came out of that was the Australian government funded a search for the real wreck, and they actually chartered the ship that found the Bismarck in the Atlantic and HMAS Sydney off Western Australia, and they found it about 5 miles or so further out than we were. We were right on the edge of the continental shelf. They found it in 2,000 meters of water, never be dived. No question, they found it with the bell on deck, AHS Centaur, the whole biz. It was extraordinary. And the cool thing about that is that, after a few years, these people who were throwing wreaths on the wrong wreck got taken out there for the very first time and threw wreaths over the side on the right side. And look, if I was visiting a grave site for my grandfather in France who died in the war, and his body was really at another gravesite, I'd actually want to know that, And so in the end, it had a good outcome. And that probably the single most satisfying thing I've ever done in diving was that dive. But I've had lots of amazing experiences. And just, recently I've been doing, expeditions with the Wet Mules guys here in New Zealand, the Pierce Resurgence Cave. We went there in 2020. Richard Harris and Craig Challen did extended their previous range in that cave. They did 245 meters and a 16-hour dive in 6-degree water. And just several months ago, Richard and Craig did another dive, this time slightly less, 230, but used hydrogen for the very first time in 30 years. Very first time ever in a rebreather to try and ameliorate the effects of the high pressure neurological syndrome while getting rid of the nitrogen out of the mix because of its density. And that was successful. So that was another really satisfying expedition to be part of. And that was just a couple of months ago. So, I've had some fabulous times in diving. And in terms of, I think you also asked about, professionally, well, we've kind of, over the last 20 years the 20 years, we've sort of made an art form out of identifying problems or questions that the diving community has in relation to diving medicine or physiology, particularly around the use of rebreathers, and trying to answer those questions with relatively simple small studies that are doable but are of high practical relevance. And we've had a terrific time with that. Just lots of really interesting studies. Probably if you're asking me, my single biggest contributor to diving medicine, in my view, would be the consensus conference that we held in 2004 in Sydney, where we developed an international consensus on what mild decompression sickness is, and an acceptance that it's okay to not recompress patients with mild decompression sickness if it's difficult to access recompression. And why is that important? It's important because that was the dawn of the age of travel to all these exotic locations that we're currently seeing. People were wanting, the most remote, the most exotic, the new experience, and so they were going to increasingly remote locations all over the world, and it was creating problems because they would ring Dan with these very mild, non-specific symptoms from places like Bikini Atoll, and then you're faced with this issue, well, what do we do? Because at that point in time, it was pretty much a standard of care. If someone had symptoms of decompression sickness and you made the diagnosis, you kind of were obligated to evacuate them, no matter how serious or not it was. Whereas once we'd constructed this consensus and we had an agreement on that, it really revolutionized the way divers were managed all over the world. And look, we're almost 20 years down the track from that consensus. And although it was very controversial at the time, it's fair to say that no evidence or even compelling anecdote has emerged that would suggest we went too far with that. It seems to have worked, and that was a big contribution to the way divers are managed all over the world, that has persisted and become relatively entrenched in practice, I would say. So those are a couple of examples of really satisfying things that I've had in my career.
Yeah, just a couple of good ones, eh?
Oh well, it all sounds a bit sort of self-congratulatory. I mean, you asked, so I'm telling you. But
it should be.
But every diver's got their best dive, So mine just happened to be the Centaur thing. Well, I won't say it was my best dive, but it was certainly the most satisfying dive project I've been involved with. But these recent things with the wet mules have been terrific as well, I must say.
Yeah. Hey, what I want to pick up on there as well, just on the subject. What's your thoughts on people doing the old-fashioned kind of self-administered recompression?
You mean in the water?
Yeah.
Yeah. Well, that is an issue that's been around for a long time. It's been a big controversy. Typically, the medical community have been against it. However, again, this is another thing that the growth, the advent of technical diving has changed that landscape a bit. So just a few years ago, 2018, I was actually asked by the Divers Alert Network in the US to review pre-hospital management of decompression sickness, which included that mild definition, revisiting that. Has it worked? Do we need to change it? And one of the questions they asked was, what about in-water recompression? Because the medical community considered it quite a few times and said, no, we don't want that. And yet now we have this population of technical divers who are trained to plan and execute decompression stops in the water. They're trained to use 100% oxygen in the water. They know the risks of doing that. They know how to minimize those risks. They know how to do it safely. In other words, is this a group that we would be prepared to endorse using in-water recompression under certain circumstances? And to cut a long story short, the consensus we came to is yes. So there is now a consensus of medical experts that says that properly selected divers with decompression sickness being treated by properly trained and equipped divers, and that is technical divers trained to at least decompression procedures level, so they know how to use oxygen, can use in-water recompression legitimately if a hyperbaric chamber is more than 2 hours away. So that's kind of where we've landed in terms of in-water recompression. So it's not, so let me be clear, it's not that every PADI dive master can put a sign on their boat saying in-water recompression provided here. That is not the intent of it. And it's not in-water recompression on air, because that has been shown under multiple conditions to not be very successful. But in-water recompression by properly trained divers using oxygen is definitely an option. And once again, I can provide you with a web link to a paper, the paper that we essentially generated to justify that decision. One of the things we did is quite interesting. It was part of that process. We dug out all the evidence that demonstrates that very, very, very rapid recompression is effective, because that's the big advantage that in-water recompression gives you, right? You can do it really quickly. And in fact, we found data from US Navy databases that David Dillett has access to. We were able to present a strong case that very rapid recompression does actually work. So that's point number one. And also we found data from early US Navy recompression table testing programs that shorter, shallower recompressions, like you can do in water, actually are effective, especially if you use them early. You can't do a table 6 in the water, right? You can't go to 2.8 atmospheres underwater and breathe 100% oxygen. That's too dangerous. But you can go to 1.9 meters, and there are some in-water recompression treatment protocols that basically involve that, especially if you use a full face mask or a mouthpiece retainer device as a safety factor. I'm just going to have to plug my computer in here because I think I'm going to run out of power soon if I'm not careful. I think we're all good. Yeah, and I have power, so no, that's fine. Yep. Yeah. Sorry, you'll just have to edit that bit out. Yeah.
That's fine. I might leave it in just for embarrassment factor of not plugging the computer in. Okay, I tell you what. Let's do another 9 questions of the 10 questions I've been asking every guest. We've just had one of those because one of the questions was a memorable dive, and I think 180 meters kind of covers that. And then we can get wrapped up, and you can get on with your merry day.
Sure.
Okay, so question number 1: how do you describe your position as a diver and medical guru to people who are not familiar with the activity of diving?
Well, I would just say that I am a diver, and like any person who's been passionate in a sport for a long time, I've evolved over a long period of time. And so as a diver, I'm now what people call a technical diver, and I use rebreathers for deeper, longer dives. That just gets me to places where I couldn't get to otherwise. I'm not a depth snob, by the way. I'm still happy to go for a nice shallow tropical reef dive. I love it, in fact. But the technical diving is a tool to get longer and deeper. And I've been very lucky to be able to wrap that passion up into my career, both as a clinician in treating other divers who are sick, but also in doing research work to answer questions that are relevant to the communities that I'm part of. So I've had a very all-encompassing diving and medical career all wrapped together, both clinically, academically, and recreationally. I don't know if that answers that question, but that's my answer.
Well, you've actually fit in a hell of a lot into what you could arguably say is a relatively short time over your lifespan. To be able to do and achieve what you've done so far is just phenomenal.
Oh, well, that's very nice of you. It's like a long, slow innings in cricket. Accumulate runs. Yeah.
Yeah. Hey, one thing I didn't ask, and I should. It crossed my mind when I was speaking to Pete the other week. With the advent of a lot more tech divers, effectively recreational tech divers that are going on holidays to these remote locations and whatnot, do you think there's going to be an increase in issues with decompression sickness due to these people being qualified and then not not preparing for such a trip like Chuck Lagoon or something like that. I can only imagine people sitting at home for a long period of time, not really doing dives to what you would call reasonable depths, and then all of a sudden doing 10, 12, 15 days on a boat diving every day.
Yeah.
Surely that's got to increase problems.
I think
possibly.
I'm not sure that it's the lack of preparation, although that could certainly contribute. It's not really what we see. What we see on those expeditions, and I've been on maybe 6 or 7 of Pete's expeditions to either Trucker or Bikini, actually more than that, and I'm going again in December too. What we see is divers who, it doesn't really matter whether they're active prior or not, they get to a place like that and they're just blown away by how good it is. And because it's trip of a lifetime, I've spent a fortune getting there, they just want to squeeze out every single diving minute that they can. And so we see them doing patterns of diving that they probably wouldn't do, like, 2 big dives a day, decompression dives, long, deepish. And then it's usually day 3 or 4 we start to see problems, as this all accumulates. So it's not really the fact that they haven't prepared necessarily, rather that they just get to an amazing place and, dive their backsides off. And that just creates provocation. That's the main issue, I think, is it's not, like, I don't think it would have helped if you'd done a whole lot of diving before you arrived. I think you'd still be likely to have the same kind of problems. It's just this, arrive in this amazing place and then just go ballistic with the diving.
Mental.
Yeah, that's typically what we see.
Yeah, fair one. Okay. All right. So if someone wanted to pursue a career similar to yours, what advice would you give them?
There are quite a few people who are doing exactly that, and I get to talk to them quite often. I've got a young medical student from the United States staying at our home at the moment who's trying to do exactly what I've done. Well, be a diver, but then there's some hard yards that have to be done, and one of them is getting a medical degree. If you really want to be an academic diving physician, so getting a medical degree, and then one of the pieces of advice that I quite often give to circumvent people trying to do what I did, which was make it all about diving medicine, is that you can't do that, right? There's no such thing as someone who only does diving medicine. There's just nowhere where you see enough divers to do that. Well, there are some people who spend their entire lives doing diving medicals, but sorry, I'd rather rip my own head off than do, you're just doing these endless medicals on people who are fit and well. That's not my idea of satisfaction. So what you need to do is do your medical degree and then involve yourself in the activities of a diving medicine unit. So as an on-call doctor, and contribute to an on-call roster. But at the same time, you need to train in another specialty that will pay the bills and hopefully have some compatible skills that you can apply in your diving medicine career. So anesthesiology is absolutely perfect. We become very good at managing critically ill people. We've got great airway skills. We know all there is to know about giving drugs that sustain life. And so anesthesia is a great choice. And also there's quite a lot of cross-fertilization between diving medicine physiology and anesthesia physiology, gas physiology, all that kind of stuff. But emergency medicine is another good one. And look, any medical specialty would do, but the ones that give you a skill mix which translates in some practical way to diving medicine, like out there in the field, when I'm on one of Pete's expeditions, the fact that someone could come to the surface and be drowned and need resuscitation, as an anesthesiologist, that doesn't faze me too much. That's not to say I wouldn't get distressed in a situation like that. Of course I would, especially if the patient's doing badly. But I know I've got the right set of skills to deal with a thing like that. Whereas if I was a dermatologist, maybe less so. You get my point. So go to med school, maintain your interest in diving, do a compatible specialty, do it in a place where there is a diving medicine unit so that you can get involved in the activities of that unit. And then you have this parallel career going forward in your primary medical specialty and diving medicine. And of course, stay a diver and keep diving. That's how to do it. And if you really want to immerse yourself and become influential, then getting involved in diving medicine research is also a good thing to do. Because the truth of it is, people don't know me because I'm good at treating decompression sickness. They know me because I've published a lot of stuff about diving and diving medicine and diving physiology, and a lot of that comes out of the research that I do. So if you really want to become influential and talk at a lot of conferences and all that kind of stuff, you need to start studying diving and diving medicine. And that's a cool thing to do too, and I was very lucky. I got to do a PhD in a relevant subject area when I was in the Navy. There are other ways of doing that, but so go to med school, do a relevant specialty in parallel with some diving medicine activity. So if you want to do this in New Zealand, you'd either do it in Auckland or Christchurch, where there are chambers. You wouldn't do it in Wellington, for example, because that you wouldn't be able to immerse yourself in the activities of a diving medicine unit. And stay a diver, advance your diving career, and do some research. There you go. There's my formula for becoming someone like me.
If you could change anything about the diving industry or scuba diving in general, what would it be?
It probably goes back to that discussion we had earlier about human factors. I mean, because my natural gravitation is towards safety, because of my role as a physician, and the things that motivate me or that I would want to change are the things that promote safety. I mean, if I was a eco warrior, I might give you a completely different answer to that question, quite legitimately, But for me, with my professional interests, if I could wave a magic wand and get every rebreather diver to use a checklist, that would be something before they jump in the water. That's probably something I would do. So it's difficult to put my finger on any one thing, but I think there's an example, if you want one, of something that would fit that sort of question.
Okay. Thinking about green and conservation, what are your thoughts on ways for us as human beings to minimize our impact on the oceans?
Well, there's lots of ways, of course, but for me, there's two broad areas. One is, pollution of the oceans and plastics in particular. And actually, we're moving in the right direction there. I think, that if you think about the change in plastics use that, you and I have witnessed in the last 10 years, there's definitely been a change and people are onto that. But pollution of the oceans is a big one. But the other thing that I think this is the big thing, is exploitation. I mean, we are overfishing the oceans. There is absolutely no doubt about that. And you only have to look at places where you explicitly prevent that from happening to see what things could be like if we didn't do that. Now, look, I get it. I mean, people rely on the oceans for food, but some of the things we see and the exploitation that goes on, it just can't go on. I mean, we need to button off on that. We need to find better ways, less damaging ways of feeding the population of the world than strip mining it of all life. And things that really offend me are these, pictures of dead manta rays with their gills ripped out, or sharks with their fins chopped off, or, if I could put a stop to that kind of stuff. But just at a high level, reducing exploitation to fishing pressure to sustainable levels, which currently we're not doing. There are places where we do, but and isolated fisheries, which are exemplars of how things can be done. But across the world, we're not doing a very good job of it, and that needs to change.
Agreed. Well, seeing as we're on the conservation bandwagon, is there any kind of conservation efforts that you're particularly passionate about? And if so, why?
Well, lots. There's no sensible conservation effort that I wouldn't support. But I guess one that springs to mind as a diver, because it's diving oriented, is, and I think there are branches of this in lots of different countries, but here in New Zealand we've got a group that focus particularly on ghost net fishing, and getting rid of ghost nets out of the ocean. And I am like, there's nothing more heartbreaking than seeing a net sitting somewhere that's caught a whole lot of things in it that aren't ever going to be used for food, and they're not species of fish. Sometimes it's birds, sometimes it's marine mammals that no one wants to catch anyway. I mean, nets are a very unselective way of catching fish, but getting rid of those ghost nets, there's a couple of groups. Well, there's one group here in New Zealand that is very active in that regard, and I really admire them because they put a huge amount of time and effort into it, and it's such a cool thing to do. It's not going to solve the world's fishing problems, but as a focused project, I think it's a super cool thing.
Yeah. No, good on you. Yeah, we've got a few ghost nets over here in Australia as well, funded by the government. I think they call them shark nets.
Shark nets, yeah.
Excuse me. Has your passion for diving or the industry itself changed over time, and if so, how?
Well, the passion's never changed really, but certainly the nature of the activities I've done. And it's, like I said earlier, it's one of the super cool things about diving is you can reinvent yourself as a diver multiple times throughout a long career. Indeed, you kind of need to, otherwise things just get a bit routine. But like I said, I've cycled through snorkeling, spearfishing, this is an approximate chronological order, scuba diving, instruction, military diving, rebreathers, mixed gas diving, photography. It's been a fantastic evolution, and sometimes I've ducked in and out of those different things over the course of the years. So it is an activity where you can do lots of different stuff. The passion levels might stay the same throughout the whole time, but you can certainly change what you do and the emphasis on your activities. The industry, well, I guess the emergence of technical diving as something that non-military, non-occupational people can do has been a real revolution, and some of the achievements of my technical diving colleagues are just extraordinary. I mean, it has its risks, but I think that is a very important evolution in the industry.
Yeah, I can't imagine what it's going to be like in a couple of 100 years.
Well, who would know? One atmosphere diving suits that you can go to 1,000 feet and not have any decompression. Who knows? We're not that far away from that now.
I agree. Now, here's a difficult question for you. Probably the most difficult question you've ever answered. What are your top 5 bucket list diving destinations?
Well, of course, some of them I've already ticked off. If you'd asked me what my bucket list was, years ago, I would have included places like Bikini and Truck, and there are 2 places that I've been to multiple times now, and never get tired of them. But if you're talking about places I've never dived, because there are some extraordinary places here in Australia here in New Zealand and Australia that I've dived. But no, if you're talking about places I've yet to dive, there's a few. I'd really like to go to the Galapagos. I've never done that. And yeah, I think that's definitely a bucket list location. I would like to, I'd like to dive the caves in Florida. That would be another bucket list. And Mexico. Now, I actually have done a little bit of cavern diving in Mexico, but I've never done the big time cave. So there's 3. I'd also really like to you notice the pattern here is that they're all places that are quite weird in their own ways. But I quite like to go into the northern. I've dived Antarctica, but I'd really like to go and do some cold water diving, perhaps ice diving up in Norway, or the North Polar ice cap somewhere. That would be an amazing thing. You get different creatures up there.
Yeah.
And I mean, that's probably 5. As a passionate diver, I'm actually pretty cool with just diving anywhere. There's fascination to find wherever you jump in the water. But yeah, there's some ideas about places I'd love to go.
Yeah. So it's creatures as well. Then it's you mentioned the Galapagos, and you've got to go. Get on one of Pete's trips or whatever. I'm going at the end of July. Yeah, July. I've got an expedition going, and it's sensational. And if you're into the big critters, oh boy, they get big and plentiful down there. That's for sure.
Yeah. No, I'll certainly take that advice.
And take a lot of SD cards with you, because you're going to go through quite a lot.
Yeah.
Okay. How would you describe the dive community to a non-diver?
It's a varied community. It's like, I think, lots of different people. One of different types of people. One of the things I often say to prospective divers is that it's a great activity for families, and it's a great activity for women, which sounds a bit kind of like off in this modern day and age, but sometimes these things need to be said. And partly the reason I say that is that women actually, objectively make better divers than men, probably because they're more sensible and not driven by the desire to strip as much biomass from the marine environment as possible every time they jump in the water. So I think it's a great gender balanced activity, although there are more men than women in the sport. I think the community consists of lots of individuals doing their own thing, but it also consists of focused groups who identify as groups. And actually, if what you're looking for is a sense of belonging or camaraderie, there's lots of that in diving if you want it. So especially in technical diving, there's lots of groups in various places that identify as sort of projects or communities that do a lot of diving together and organize things together. So I think it generally is populated by nice people. There are some big egos, of course. Rebreather 4 and 4. I mean, that was like 300 of the biggest egos in the world all crammed into one room. But actually, they all played nicely, and I think I think it's generally you go to a meeting like OzTech or something like that, and the vibe you get is pretty warm and collegial. I think. I actually think it's evolved in that way. When I first got into diving, there was a lot of cliquiness to it, and people who considered themselves sort of above everybody else. But I think that's all sort of worn off, and basically it's a nice community. Yeah, sorry, a bit of a long-winded answer, but yeah.
No, it's a brilliant
question.
answer. This is why I ask these 10 questions to every guest that comes on, because albeit, some answers are very long, some are very short, but they're all coming to the same thing, especially that one. It's I think for me it's the closest thing when it comes to camaraderie that I've ever experienced outside of the military. Quite frankly, I fucking love it. It's great. Yeah. Last one, and I think I know the answer to this one. Of the many safety procedures we have in the industry, if you had to choose one as the most important, what would it be?
Oh yeah, well, we've had this discussion. In terms of bang for your buck, in terms of objective evidence that it would result in less deaths, without question, it would be pre-jump checklists for rebreather divers. There's it's easy. That's an easy question to answer. And we know this from parallel fields, and in fact some research in diving too. The Dan group published a really big study looking at the efficacy of pre-dive checklists, not pre-jump checklists specifically, but it did reduce critical events in the water. It's a very underrated study, in fact. But we know from aviation and medicine that short killer item checklists will prevent bad things from happening, and there's no question. We know that these bad things happen, and rebreather divers and checklists could prevent them if people did them. So that's it. Easy answer.
Done. Get them done. Happy days. Simon, let's wrap this bad boy up and get on with the weekend ahead. Thank you so much for your time and coming on the show. Ladies and gents, thanks for listening in, and all of the details that we've been talking about will be in the show notes. And see you all soon. Bye for now.
Scuba Goat Under the Sea, the podcast for the inquisitive diver.